Hi everyone, my name's David Beaton and I'm a gastroenterologist currently working in Northumbria NHS Foundation Trust in the UK. It's a real pleasure to be able to present this video looking at our most recent accepted paper which analyses colonoscopy quality in the UK utilising data from the National Endoscopy Database. The importance of colonoscopy quality has been extensively researched in the past. We know that from a service level, especially in a pressurised system such as the NHS in the UK, which already suffers from large backlogs, it's important to get endoscopy right the first time and prevent having to do repeat procedures. Most importantly though, colonoscopy quality is vital from a patient perspective, as we know through extensive research that a high quality index colonoscopy is much more protective and protective over a longer time against subsequent colorectal cancer. In the UK, we're fortunate as we now have the National Endoscopy Database. This is a centralised dataset which automatically receives uploads from electronic reports produced by endoscopists. Almost every site in the UK now uploads to this database, which gives us a vast wealth of endoscopy data to analyse. The aim of this analysis was to calculate key performance indicators in the UK for colonoscopy, and then subsequently to look a bit further to see if there's any ways that we can improve these in the future. To achieve this, we looked at 1 year's worth of colonoscopy data in the National Endoscopy Database. The time period was 2019 to 2020, and at that stage, around 80% of UK endoscopy sites were uploading, giving good generalisable data. We calculated baseline KPIs as per BSG or British Society of Gastroenterology standards, and then subsequently performed multivariate regression analysis to look a bit closer at certain factors associated with quality and see what we could learn from these. Data from almost 600,000 colonoscopies uploaded through the year was analysed, and overall quality was excellent, with a cecal intubation rate above 93%, polyp detection rate above 37%, and a discomfort rate, so the proportion of patients recorded as moderately or severely uncomfortable, lower than 5%, which is really reassuring given that 99% of colonoscopies in the UK are performed using either conscious sedation or no sedation at all. However, these headline figures mask the fact that we have a significant cohort of colonoscopists who are not achieving these standards, with over a third not maintaining standards in cecal intubation, polyp detection or discomfort, and that included over half of low volume endoscopists, i.e. those performing fewer than 100 colonoscopies annually. We then looked at the difference in colonoscopy quality across different settings. Firstly, we noted that the quality for training versus non-training colonoscopies was very similar. However, there was variability based on endoscopist specialty, with surgeons recording lower cecal intubation rates, lower polyp detection rates, and higher discomfort rates when compared to gastroenterologists. This finding isn't novel, with multiple research also showing this link. However, one of the limitations of many of these studies has been the inability to incorporate case mix when we're trying to explain the reason behind it. We then performed logistic regression analysis looking at the importance of case mix and unsurprisingly found it plays a vital role in colonoscopy quality, with indications such as surveillance procedures being very likely to reach the cecum with lower discomfort rates, female sex being associated with higher discomfort rates and lower completion rates, and patient age increasing the risk with increasing age of incomplete or uncomfortable procedures. We then built upon these case mix adjusted models with the addition of further variables. The first one was withdrawal time. So the completed negative withdrawal time for each endoscopist. And we found that endoscopists who had longer withdrawal times were more likely to identify polyps, but vitally, they were also more likely to identify large polyps, so those 10 millimeters or greater. And you can see the adjusted odds ratios for that below. The importance of this is that it's missing these large polyps that likely accounts for a high proportion of post-colonoscopy colorectal cancers. So this is a really important metric of colonoscopy quality. We then sequentially looked at the importance of specialty, annual procedure numbers, and then a combination of both. Unsurprisingly, even after case mix adjustment, gastroenterologists were performing at higher quality than surgeons. But interestingly, when we looked at annual procedure numbers, there was huge association with endoscopists who performed higher annual procedures, much more likely to be performing high quality colonoscopy. And when we put both of these factors in together, we found that actually the problem with surgical colonoscopists isn't across the board, and it almost evaporates as soon as you get above 200 colonoscopies annually. So the problem with colonoscopy quality in surgeons seems to actually just be that they're overrepresented by low volume colonoscopists. So our findings show that colonoscopy quality in the UK is improving over time and remains at a very high level. However, there's still a significant cohort of endoscopists masked within this who are failing to meet minimum standards, and we need to work with them to try to resolve that issue. One of the ways that we could probably do that is looking closer at annual procedure numbers and implementing recommendations for annual procedure numbers for endoscopists, as the association with low volume endoscopists and quality has been really emphasized in this analysis. The other method that we can look at is really focusing on withdrawal times, as that's a vital performance indicator for endoscopists. Although we had very generalizable data for the UK, one of the limitations is that around 20% of sites weren't uploading, and there is a risk of bias due to that. Because this is anonymized data from the National Endoscopy Database, we had to use polyp detection rate as opposed to adenoma detection rate. And endoscopists reported their outcomes. So factors such as discomfort rate are likely underestimated overall. However, we hope that you've enjoyed reading this paper, and if you have any questions, please do get in contact. Many thanks.